Namaskar and good afternoon to everyone who's here. But I know that there are also a lot of people online listening. So let me convey my best wishes and greetings to all the staff of all the CSIR institutes who are gathered here. Thank you very much, Madam, for your firstly honoring me with the invitation to deliver the one of the lectures in the AMRIT series, which you have initiated from last year, and looking at the list of previous speakers, really very eminent people. So I'm very humbled that I am also in that list. And it's a great pleasure to be back here. Of course, I've been in this building many times before, especially when I was in the ICMR, both when I was director of the Tuberculosis Research Center in Chennai, and I used to come here to have some discussions with people. We did have some collaborations, but also as DG ICMR, I have come here many times. So it's a great pleasure, and I hope that there will be much more and further strengthened relationship between ICMR and CSIR, because I think lots of complementary strengths, and coming together, I think one can be even stronger rather than individually. So some of the suggestions I'll come to later in my talk. But so I'm not going to use slides, and I wanted to have more of just a reflection on what I think about the priorities. And I know that CSIR works on many, many areas beyond health. So I don't want to make it so technical that all the non-health people, get bored and feel that it's not relevant for them at all. And I want to tell you why each one of you, whether you're working on road design or whether you're working on materials, or whether you're engineers, structural engineers, every profession and every aspect of our life actually has some impact on our health, even though it may not be so obvious at times. So I don't think there's any CSIR institute which is working on something which is not directly or indirectly related or could contribute to health for all, as you mentioned. In fact, just yesterday I was reflecting that SDGs, when we look at the Sustainable Development Goals, number 3 is health and well-being for all, and then you have 16 other SDGs. But actually, if we had just one SDG, and if we said health and well-being for all on this planet, then actually, if you really think about it, it covers all. You don't need 17 SDGs, because it would cover your biodiversity, your plants, your animal species, your life above on land, life underwater, the need for energy, the need for safe water, sanitation, gender equality. All of this would actually be captured in one. And so you can think of SDG 3 as the docking point for all SDGs. And if any one of the other SDGs are not going to be attained, it will definitely have an impact on health and well-being. Now, CSR's mission, of course, is to provide scientific and industrial R&D. This is what your mission statement says, that maximizes the economic, environmental, and societal benefits for the people of India. And I think it's important to remind ourselves again today of the words environmental and societal, which is there in the mission statement. It is not only economic. And sometimes, in the rush for looking only at numbers and looking at growth in terms of GDP, it's very important, no doubt. But we have to ensure that there is also environmental and societal security, because without that, only financial security is not going to lead us to a happy life. We could all have bigger bank accounts, but will we be living a happy life if there are no forests, if half the species in the world are wiped out, etc.? So this is why I think it's important, and your mission statement encapsulates that. And there are many interlinks actually now. There's a lot of research and data which links societal well-being and mental health with the presence of green spaces, for example, in urban areas. And randomized trials have shown, Dr. Prabhakaran and all from PHFI, they've done many trials with cohorts where they've shown that people who live close to greener spaces can get up and go for a walk. You can open your window and look at some greenery. They generally have much better mental health and even much better control of high blood pressure than people who live in areas which are very far removed from green spaces. So This is why it is important, to think of our environment when we think about our own health. Now, of course, industry for you all, it spans across. I think we're not just thinking about manufacturing and factories, but you're also thinking about agriculture, you're thinking about services, you're thinking about, diagnostics, the healthcare industry, and many other sectors, materials, and all of the different sciences where you have this type of translational outputs. Now, India is a very unique country in many ways, not just because we have a population of 1.4 billion and we are now the largest country in the world. As you know, we overtook China sometime last year, but we also have a demographic dividend, which very few other large countries have. And what does that mean? It means that we have about 350 million people in the age group of 10 to 24 years. This is the workforce of the next 25 to 30 years, and it's a huge workforce. And therefore, if we invest in them and build their capacities and use them when they grow up and they get into the workforce, then that is what can really drive our economy in a very positive direction. And this demographic dividend will not last. It's only a window of maybe 30 years or so that India has, just like other countries also had their window. And today you see what is happening in China. They are an aging population. So they also have a population of 1.4 billion, but their population over 60 is, I think, close to 30%, whereas we are still in single digits. We're just approaching double digit figures of population above 60%. However, by 2050, we will have a population of over 60s who are above 20%. So we'll have to prepare for that. But for the time being, I think this is the time to really make use of that demographic dividend. We have huge amount of natural resources, we have biodiversity, we have something like 20 different agroecological zones, and if they are further divided, there are more than 240 or so different agroecological zones in our country. And again, that's, you can look at it from both ways. It's a opportunity because of the different varieties of biodiversity that we have, and it could also be a challenge. And I will talk a little bit about climate change and the threat that we are going to face from that a little bit later. As you know, we still have we have reduced our total fertility rate. So when people talk about the population just growing and growing, yes, it was the case in the past, but efforts made in the last 30 years or so have ensured that our total fertility rate has declined from, it was around 3.5. That means every woman had, or every couple had 3.5 children. So the replacement was much more than, but now the TFR is 2, which means that the population stabilizes and does not continue to grow. And it is expected that this will fall further. And we see in many countries now, like Japan and the Scandinavian countries, the fertility rate is so low that they are worried that they will not have their own adequate population left, after some time. So there are many incentives being given to people there to have children so that they don't run out of like their own ethnic population. So if you look at some of our health indicators, our life expectancy is around 70, 72, something like that. It's always a little bit higher for women than for men, a couple of years difference. But what is we should pay attention to is healthy life expectancy. So healthy life expectancy in India is only about 60. So what it means is that even though we may be living longer, the 10 years of our life are actually with a lot of chronic diseases and morbidities. So the idea really is to have not only a longer life, but a healthier life, because otherwise your quality of life is not going to be that good. And now, of course, we have many people we see around us living into their 80s and 90s, but a lot is going to depend on whether you enter that age, 80s and 90s, healthy or not, because otherwise you're going to be, or we are going to be, a burden on society. So I think healthy life expectancy is an important indicator that we should measure our progress by. Are we improving or are we not improving? Then when we look at nutrition, and you mentioned that we are no longer in an era of food insecurity. We are very much food secure. We have enough food in terms of cereals to feed our population. We have, in fact, enough surplus stocks kept in the FCI, etc. They're able to export uh, rice and wheat. But if you really look at what you need for, again, a balanced diet or overall complete nutrition, then you start finding the gaps. The gaps are in protein, in oil, and in micronutrients. So protein, a large part of proportion of Indian uh, do not get adequate protein intake, whether you're vegetarian or you're non-vegetarian. The protein sources may differ, but the quantity of protein that people should get, and especially young children should get when in their critical growing years, is inadequate. Similarly, micronutrients are inadequate, and there are many reasons for this. I think the most important reason is that we do not have dietary diversity. If the National Institute of Nutrition, the ICMR institute in Hyderabad, which does the periodic surveys of nutrition, I think that again just started a very massive survey across India, which will give us a lot of useful information. But the data they collect shows that over 90% of Indians are not getting a nutritious meal according to what they have defined as a healthy meal with all the vitamins, minerals, adequate amount of protein, fat, fiber, etc. And for a large number of people, this is because they cannot afford. We say eat 5 helpings of fruits and vegetables in a day, but a lot of people cannot afford to get that. They cannot afford to get high quality protein. According to the FAO, 74% of Indians cannot afford to have a plate of healthy food or 3 meals of which are balanced and nutritious. So this leads to obviously the micronutrient deficiencies, and that could be part of the reason why we see still a high percentage of anemia. So even though we've improved on many other indicators, that anemia problem has been very, very recalcitrant and not amenable, even despite the fact that we have the National Anemia Control Program, we have the Anemia Mukt Bharat program and things like that. We have Poshan Abhiyan for young children. But the issues of malnutrition, the malnutrition encompasses undernutrition, which is stunting, wasting, underweight. The last NFHS 5 showed that stunting was about 35% and wasting was about 18% or so. Now, the next NFHS round has started. We should see whether we have made progress or not. It also varies. It varies by state. India, again, is such a large and heterogeneous country that to give one data point for the whole of India sometimes does not make a lot of sense. And this is why we need data that's disaggregated by state, by district, even sub-district level. You will see variabilities in the same district among various population groups. If you take any health indicator and you look at it by socioeconomic status, there is a clear gradient. From the bottom quintile to the upper quintile, you'll see that the same, whether it is infant mortality rate or whether it is stunting or whether it is TB, there is a gradient. Similarly, if you take the scheduled tribes, for example, look at our tribal area health indicators, they're always much worse off in majority of cases than the health indicators of people who live in urban areas, for example. So there's a rural-urban divide, there is a male-female divide, there is a divide between socioeconomic strata. So when we look at data, we need to look and analyze it according to all of these variables and then try to understand where are the gaps and where can the policies actually make a difference, the biggest difference if they are directed. Now, before I move on from nutrition, there's another very important emerging problem today, and that is what we call the double burden of malnutrition. We usually tend to think of malnutrition as children who are stunted and wasted or adults who are very thin with a low BMI. But malnutrition also encompasses the other extreme, which is overweight and obesity. And every National Family Health Survey is showing that overweight and obesity is increasing, both in adults as well as in children. And that is a very worrying sign. And when we talk about the double burden of malnutrition, it can be at the national level, but even at the community and household level. within a single household, you can find people, adult in the household who is obese, a child who is undernourished or stunted, as well as a woman who's anemic. So it's very complex that all of these things can coexist. You can have somebody who's overweight as well as anemic because they all come from different sources of the food. Now, the first 1,000 days of life are the most critical for, in terms of nutrition, for both physical and mental and cognitive development, right? That means the 9 months of pregnancy and the first 2 years of life. This is when the brain really is growing very rapidly. And in fact, after the age of 3 or 4 years, the brain does not actually grow that much. So if you measure a baby's head circumference, the head circumference is about 35 centimeters at birth. And by the age of 4 or 5, it reaches 50 centimeters. That is the amount of growth in the brain. And adult skull also is around 52 centimeters or so. So later childhood, the brain is not growing. So if we don't pay attention to nutrition and to the environment that those babies are being brought up in, we will be putting at risk both physical as well as cognitive development. So I think when we think about human capital for the future, because every country which wants to be a superpower has to depend on its human capital. You can have your natural resources, you can have other resources, but if you don't have human capital, you can't build an emerging economy or a developed economy. And so this is why it's so critical today to really see how our mothers and babies of all, wherever they are, whether they are rural or urban, they are taken well care of. And another advantage of doing that would be that women would come more into the workforce. There's a lot of data nowadays, you see in the newspapers, that we have low participation of women in the workforce. We have to increase women in the workforce. If you ask the question why, the answer will be that the social care responsibilities, child care responsibilities, and elderly care responsibilities, they fall actually on women more often than not in most cultures, including in India. This is a universal phenomenon. And during the pandemic, many more women professionals had to give up their career to take care of their children than men. So men's careers progressed during the pandemic. They wrote more papers. They became much more productive. Women suffered. This is data that's available globally. So if we want really to give women equal opportunity at the workplace and to have the same a level playing field as men in their professional careers, then we have to address the core issues why women are not able to participate. And there is something Dr. Rohini Godbole said that always sticks with me, that for a woman, her biological clock and the scientific or professional clock are both running at the same time. So when a woman is in her late 20s, early 30s is the time when she's most, can be really progressing very well in her career, post PhD, getting into a career in science or any other career for that matter. And that's the same time when they normally have to also think about the family, having children, etc. So I think this is something the policy environment really needs to think about. I know that, as far as the DST is concerned, there have been many committees. In fact, on Sunday was the International Day of Women and Girls in Science. And there was I think you were also there, the Swati portal was launched. And when I spoke there, I spoke about 4 things which a country needs to do in order to create this equal gender opportunities. The first is equal pay. Of course, in the government, I think we don't have a problem, but still in the private sector and in different professions, women get paid less than men for the same work that they do. So I think equal pay has to be there. The second is that parental leave. So the Scandinavian countries, what they have is a system of parental leave where women get the mother gets 6 months, the father gets 6 months. And so you can take whichever order, but cannot be exchanged. The father doesn't have the option to say that now I'll give my 6 months leave to the mother and I'll continue to work. No, that is not acceptable. Father will get fully paid 6 months of paternal leave, and that actually not only builds the relationship between the child and the father, but also helps the father to understand what is it involved to bring up a child. And so this type of policy where 1 year actually shared between the two parents, they get paid leave. The third is, of course, to address issues of gender-based violence, sexual harassment, etc., to have good policies and regulations to address that. And the fourth very important one is the issue of the child care or elderly care, so that the women are not bound down by that. And so if, for example, we had crashes everywhere, uh, at workplaces, then it would be, and of course, we have to agree that many women are in the informal workforce also. In fact, there are very few in the formal workforce. So we need to create a system where we have creches for children 0 to 3 or 6 months to 3 years, which they can be left before they can go to an Anganwadi or a Balwadi. And then, of course, they go to school. And very often you may even need after school care till the parent is able to pick up the child. So most developed countries, have this system in place, and thereby the woman does not have to worry all the time about the child being left at home with an older sibling. You go to villages, you'll find the child is at home with an older sibling or sometimes with a grandparent. So that older sibling also suffers because that girl then has to miss school in order to take care of her younger brother or sister. So I think that's just on the gender issue and the fact that nutrition is so important. And again, nutrition for adolescent girls, making sure adolescent girls are healthy mentally and physically. There was a study that Dr. Bhan had initiated actually a long time ago and done in some of the slums around Delhi that showed that they actually took young newly married women and they screened them for a number of disease morbidities because they wanted to see if you can identify and treat those minor things that women may have, then you actually produce a healthier baby. Can we reduce low birth weight? Because low birth weight, we still have a very high proportion of low birth weight, that is babies born less than 2.5 kilos in our country, and we're not able to really, again, make a dent. So that study showed that on average, a young, otherwise healthy, newly married woman had an average of 3 to 4 morbidities, which could be anemia, urinary infection, thyroid problem. So when you actually screened, you found all of these things. And then when you treat that, and then the woman gets pregnant later, once she is actually not suffering from these problems, the child born is likely to be healthier. So it just shows that there's a lot of morbidity in the population which is undetected. Now, similarly, there was a very large study that was supported by the ICMR called the IN-DIAB study, DIAB for diabetes. So the In-India Diabetes survey took place over 15 years because it covered all the states of India. So it took a very long time. But they went state by state and they did a representative population survey. And the findings which were published last year in the Lancet, of course, they were published whenever the state level data was available, but the overall India findings were published was actually very shocking. So what they found was that 11%, and this was in adults above 18 years of age, 11% of Indians are diabetic in this survey. And another 15% are pre-diabetic. So pre-diabetic means that already your glucose metabolism is altered. And if you don't change your lifestyle, then you're going to end up with diabetes in a few years, maybe in 4 or 5 years. So 15% are pre-diabetic, 11% are diabetic, 35% had hypertension, and 81% had dyslipidemia, that is abnormal cholesterol and lipids in the blood. And another, I think 38 or 40% had abdominal obesity. So abdominal obesity, that is your waist circumference, if it is more than 85 centimeters for women and 80 centimeters for men, then you're considered at high risk, also for some of the metabolic disorders. So what this survey really showed, and they also looked at rural, urban, and everywhere urban was more than rural. And if you look at the map of India, they had colored it, with different gradations. So generally, the darker the color, the higher the prevalence. The southern states, the more developed states like Kerala, Punjab, Tamil Nadu, Karnataka, then Punjab, Haryana, Goa, they all had the very highest rates. So so-called development indicators were also associated with the highest rates of non-communicable diseases. Whereas the middle belt of UP, Bihar, Chhattisgarh, Jharkhand, Madhya Pradesh, Orissa, they had very high pre-diabetes levels. So what it showed is that those states are a little bit behind these other states. And if we keep on doing what we are doing now, we will end up in the same situation in those states also. But to me, it indicates that we have a window of opportunity to intervene and to prevent those people, millions. And we are here talking about hundreds of millions. So in India, of course, everything is in very large numbers. So when you say 11% are diabetic, we're talking about 130 million people. So if you say another 15 million are going to become diabetic, another 230 million people. So it's not a small number here. It's a huge burden on the health system, because diabetes means lots of long-term complications can happen. It is extremely difficult. I have had many diabetics in my family. I know how painful it is when they develop, different complications like nerves. They lose their sensations, the eyes, vision, the kidneys, they are on dialysis, etc. So yes, we are building a lot of tertiary care hospitals now, but how many will be built? We will never be able to accommodate all the people who get sick if we don't pay attention to prevention and early disease detection. Now there's a connection here between agriculture and nutrition. I'm so glad that you mentioned it right at the beginning, because if we continue to eat basically a cereal heavy diet, then that is the major trigger for all of the pre-diabetics to turn into diabetes. Now, last year was International Year of Millets. 2018 was a national year of millets in India. A lot of awareness was raised about millets and their health benefits. But we also need to look at the policies through the value chain. How do we make more farmers grow millets? How do we actually get them processed and get them into the market and then available at reasonable prices so that more people can eat millets? It's a way of diversifying. It's not that millets are it's not the sort of golden remedy for everything, and they don't cure diseases or anything like that. It's just that they have a lot of properties in them. They have high fiber, they are gluten free, they have more micronutrients, and therefore, and many of them have higher protein content than rice. So you shouldn't polish them, of course. If you polish millets like you polish rice, then all that is gone. And might as well be eating any grain which is highly polished. It's not going to give us any nutritional benefits. So I think nutrition and health are very closely linked. Obviously, agriculture and nutrition are very closely linked. So these three sectors really need to work together, I think, to address this challenge. Then, of course, we've made progress on maternal mortality rate, infant mortality. Again, we're making progress on all those. A word on infectious diseases, because I worked on TB for most of my life. And, the progress is very slow. Let's put it this way, that despite all the global commitments, the national program, and the fact that today we have new drugs also available, but still the progress, the decline in TB incidence is extremely, extremely slow. So we will not be able to achieve the 2030 targets of TB elimination. India, as you know, advanced it. India actually said we will eliminate TB by 2025. The global target is 2030. But the rate at which TB is going down, and there are three targets for TB. One is to reduce the incidence, one to come down to less than 10 per 100,000. The other is to reduce mortality and basically to try to eliminate, because TB is a treatable disease. Why should people still die? And yet we had 450,000 people die of TB in India alone last year, and 1.3 million people globally died of TB. A disease which is treatable. It's not fully preventable because we don't have a vaccine for TB. Now, there was a trial done, again supported by the ICMR and started when I was still in ICMR, called the Rations trial. And the first time in the world that the trial looked at nutrition and TB. And what it did was in Jharkhand, in 4 tribal districts of Jharkhand. It was a randomized trial done in the community and done during the COVID pandemic. So really hats off to the investigators for continuing with the trial and really conducting it, in a high quality way. They showed that by giving food rations to the families of TB patients, not to the TB patient, to the whole family, a good amount of calories and protein was provided for each member of the household, adult and child, compared to the control, which got no food supplement to the family. All TB patients in India today are supposed to get nutritional supplement So that is unethical to randomize. So TB patients got it, but the families got it only in one group. And the result was quite astounding. There was almost a 50% reduction in the incidence of TB among the household members or contacts, we call contacts, of TB patients whose families were given the food supplements for 6 months. As I said, it was a very good basket of food. It was not just rice. It was a lot of protein, oil, etc. that was given. So this trial made waves globally. So I was very happy because everybody said that after all these years, the evidence came from India that nutrition is such an important risk factor for TB. We have known for a long time nutrition is a risk factor, but nobody had shown in a randomized trial that by giving food, high quality food, you could reduce the incidence of TB. So another reason why nutrition is important. Infectious diseases and nutrition, sometimes we think there's no connection. This is different, that is different, but actually it's all connected. During COVID, we saw COVID is a virus. If it was like influenza or something, you get a viral infection. Some people get a little sick, you get pneumonia, you get better. Some people deteriorate and die. But COVID turned out to be very different because it basically, those people who got sick already had some underlying, what we call comorbidities. So some kind of chronic disease. And the fact is that COVID has left a lot of post-COVID sequelae and syndrome, which we are still finding out. We're still understanding how it has had an impact on the cardiovascular system, on the brain, and practically on every organ system of the body, because it's a very pro-inflammatory kind of pathology. So in addition, apart from TB, we have infectious diseases still, which are a burden for us. Malaria. We have dengue, which is the fastest growing infectious disease in the world globally, because the mosquito has adapted itself beautifully to urban environments. So as urbanization increases, the Aedes aegypti mosquito is able to thrive because of the way our urban environments are constructed. And then, of course, you have also other vector-borne diseases. The same Aedes also spreads Zika and chikungunya. And then you have scrub typhus, which is under the radar. Many people have not even heard of scrub typhus. But actually, if you look at the data, you will find that scrub typhus is one of the most common causes of fever in large parts of India. It's spread by the bite of a tick, and it can be fatal if it is not treated. But the treatment is very simple. It's just tetracycline antibiotics. Very effective treatment is there, but you have to recognize that it's scrub typhus. So one of the issues I think which is relevant to bring up here is the lack of diagnostics in our healthcare system. And because there's a lack of diagnostics, there is improper treatment very often. And you mentioned antimicrobial resistance. One of the biggest threats to health globally, pandemic made it worse because lots of people took more of antibiotics with or without prescription. So if you look at AMR rates across the world, they have increased. And in India, they're particularly very, very frightening if you look at some of the ICMR data that comes out of their surveillance systems across the hospitals. So the problem lies with this kind of indiscriminate use of antibiotics. Just for an upper respiratory infection, for a viral infection, antibiotic is not going to do anything, but still the general practice is take a course or half a course of antibiotic. But it is also the use of antibiotics in the animal and the veterinary sector and fisheries, etc., especially the large-scale poultry farms, pig farms, etc. They use a lot of antibiotics, which spill over into the soil and then get into the system. Plus, if you look at our water, our rivers, there's so much of effluents that are being released that there have been studies showing that wherever there are a lot of pharmaceutical factories, if you sample the water in the rivers there, then you'll find a lot of antibiotics. So again, I think one is to step up surveillance and get better data. And wastewater surveillance has obviously now become quite something people talk about. It used to be done only for polio. Then people started using it for COVID in many cities. And it clearly it can be used also for things like detecting antimicrobial resistance. And you can at least monitor over a period of time what is happening. But looking at the data very closely is important. And then, of course, on infectious diseases, finally, we have the viruses and the bacteria which can cause epidemics and pandemics. Now, at the WHO, we have something called the R&D blueprint for epidemics. This was set up after the Ebola outbreak of 2014-15, when it was felt that WHO was not prepared and neither was anybody else prepared to handle the Ebola outbreak in terms of uh, scientific response. How do you respond to an outbreak of a deadly virus? This was the first time that it was happening at that kind of a scale, and the response was uncoordinated. So WHO was then asked to develop a methodology for it, and that came in very useful, I must say, during the pandemic, because in the first few weeks of January, when we heard about this atypical pneumonia cases in Wuhan, and then on the 10th of January 2020, the Chinese scientists had done the genomic sequencing and made it publicly available. So we knew it was a novel coronavirus. And the very next day, people started working on vaccine development as well as diagnostics. So diagnostic, the PCR SOP was ready within 48 hours, actually, and it was disseminated so that even in India and the NIV, the PCR test was up and running, within a matter of a week or two. But the point is that we convened about 400 scientists globally in Geneva in early February 2020, to develop a research roadmap for COVID. And that was not only focused on diagnostics or vaccines or therapeutics, but looked at all aspects from transmission, the origin of the virus, which we still don't know. We still haven't found out exactly where the virus came from and how it jumped into humans. What was the intermediate animal? We don't know that pathway. But many other things we know. We know so much about the way it's transmitted, about its epidemiology, its clinical features, and of course, the clinical trials that were done showed us how to treat and prevent as well. And the vaccine development, all of that took place because the WHO was in a position to put out guidelines, but also standards and benchmarks. So I think, again, it's a lesson for us if we're trying to develop a product for something to address a particular problem. Could be a vaccine, or it could be something else in some non-health related field. It is very important to develop what we call a target product profile. What is it that you're trying to develop? What are the ideal characteristics of that product? Because if you first write that down, then it becomes easy for the scientists who are working on that problem to say, okay, this is where I have to reach. So for a vaccine, it would be efficacy, it would be safety, it could be storage conditions, it could be the fact that it is lyophilized, thermostable, all of those properties you can think of, and you can write it down as a target product profile, and you can have an ideal scenario, and you can also have a next to ideal scenario, because you may not always get the perfect product. So we developed target product profiles for vaccines, for drugs, for diagnostics. We also had the regulators. We were able to convene all the regulators, major ones around the world, including the DCGI from India used to participate, and have discussions on the regulatory benchmarks. Because again, in an emergency, we cannot have confusion about one country will approve something, but the next country doesn't agree with that. So that would have caused a huge amount of delays in getting people access to the products. So it was important to have that harmonization, and the regulators all agreed that the benchmarks and standards that were developed at that early time in April of 2020 by WHO expert groups, that they would adopt those benchmarks. Later on, of course, some of them got modified as we learned more about the products. So I think regulatory system is also very important for innovation, because they can, in a way, they are mandated to protect the health of the population. So they have to ensure that products are safe, but at the same time, they also have to encourage innovation, because you cannot take a very conservative approach, because then you will never have indigenous products coming which can help the public health of our own that we need, right? So we cannot wait for someone else somewhere else to do the innovation and then bring it to us. I mean, that's the old model. That is no longer the case. And we demonstrated during the pandemic that India was very much capable of developing high quality and affordable products that are suitable for our own population, whether it is rapid diagnostic tests or whether it was vaccines. The gap came in drugs, and globally there is a gap in antiviral drugs. There's not much of investment, there's not much of R&D, and there's really not been many successful antivirals developed. So I think that's an area where we should also focus, because in the future, the next outbreak of a virus, maybe we'll be able to develop a good vaccine, maybe we will not. You don't know the nature of the virus that's going to strike next time. And so it's equally important to put emphasis also on therapeutics, on drugs. And we know that for COVID, we tried so many antiviral drugs that we already knew, but unfortunately, hardly any of them, had any efficacy. So they were given up. Now, we can keep talking about infectious diseases, and maybe during the Q&A, we can take it up again. But the third big area, so non-communicable diseases, communicable diseases, which is infectious diseases, and the third group of the health burden of the country is what we call injuries and others. And this is things like both intentional and unintentional injuries. That means suicides. We have about 170,000 people who die of suicide every year. Road traffic injuries, sadly, that's going up. So as our roads are getting better and there are more vehicles on the road, speeding faster, road traffic injuries in 2023 had increased. The only year in which they went down, you can guess, was 2020, because there were lockdowns and there was nobody on the road. So there were no traffic accidents. Orthopedic surgeons did not have much of work during that year. But this year it's really gone up. And so we really need to look at reducing the road traffic accidents, but also reducing fatalities. The accident occurs, but at least we have to reduce the mortality due to that. Natural disasters are going up. As we know, last year, it is estimated that on 85% of the days in 2023, there was a natural disaster in some part of the country. It's a flood, a drought, a cyclone, or a prolonged heat wave. So 85% of the year we had something happening in some part of India. And with climate change, that's likely to be the new normal. And then we have substance use disorders, tobacco, alcohol, and other substances. In fact, in the US now, their life expectancy has been going down. I think it's one of the few countries in the world where the life expectancy went down. And first, people thought it was because of COVID. Many countries showed a dip in life expectancy during the COVID years. But now it turns out it's because of substance abuse. The fentanyl, the opioid addiction there has become so bad that it's actually reduced the life expectancy. So in India, I think we don't have the opioid problem to that extent, but we do have an alcohol problem in many parts of the country. And it does generate revenue for the government, but it also generates a lot of liver disease and chronic ill health, plus a lot of, I think, gender-based violence is also linked with alcohol. So it may not be that high on mortality, but I think on morbidity, it's bad. So that is how the global burden of disease actually looks, and segments the burden of disease: communicable, non-communicable, and usually nutrition and injuries. All of those come together. Now, when I was in the ICMR for the first time in 2016, we came out with a state-level disease burden report for India, for the whole country. And the reason that was very well received is that for the first time, states actually saw what their own health burden was. So Bihar is very different from Kerala, but there was no data which had been consolidated. So it was actually done with collaboration with the Institute of Health Metrics and Evaluation in Seattle. They have the methodology to produce the GBD report, and with Public Health Foundation of India. And we had a whole report state-wise, what is a disease burden. Policymakers then were able to look at and say, okay, this is what the problem is for my state. Let me make a policy which will address that. So I think it's really important, as I said earlier, for a country like India to have that type of disaggregated data that policymakers can look at. And I think it's very, very useful, and it also helps them to prioritize, because there's always a limited funding. Funding is never enough for everything. So if you have a limited pot of funds, what do you prioritize would depend on where your greatest health burden is. But in all of this, I think we have to remember the risk factors for health. So once you get a disease, you're looking at the end result. But what is it that caused the disease? And this is what we call the social and environmental and commercial, and you can add other elements to it, determinants of health. And again, this is tracked globally. And globally now, today, the number one risk factor is high blood pressure. I told you 35% of Indians adults have high blood pressure. I hope all of you have your blood pressure checked regularly. If you don't, please do, because it doesn't give you any symptoms, and it's very silent till it becomes so high that you then suddenly get, a severe, either a angina or sometimes a stroke and things like that. So BP is something you have to check. There are no symptoms, it won't be visible. So that's the highest risk factor today in the world, high blood pressure, followed by poor diet. And we talked a lot about diet and nutrition. So poor diets, and now poor diet means also more of ultra-processed foods. Ultra-processed foods are really contributing a lot to our ill health these days. We have moved away from natural food, and it's much easier to buy and eat things which are already pre-cooked. And, especially the younger generation now, I think only survives on whatever Swiggy is delivering to them. They don't want to eat at home. So the commercial, that's what's called the commercial determinants. Because what I also find is that they make claims many times, these companies, on products which are not true. So again, we need a food regulator who is very, let's say, proactive in making sure that nutrition is not compromised. So for example, there are many products where they will advertise it as, being very nutritious. These are sometimes health drinks, having a lot of protein, building your muscle, doing this, doing that, with photographs, and a lot of celebrities endorsing these products. If you read the contents on the back, you will realize that there is nothing there which is going to do all of these things. It is again mostly a tasty product with a lot of sugar in it. So other countries, what they have done is to address this issue of high salt, high sugar, and high fat. These are the three things which we have to avoid. They have brought in what is called the front of pack labeling, which means that on the front of the pack, you have a traffic light signal. If you exceed certain threshold, you will get a red. And if you are below certain threshold for salt, sugar, and fat, or sometimes some countries will pick up only sugar, saying we'll act on sugar first, you get a green. Some countries have taxed. I think we also do tax sugar. We do put a higher GST on sugar sweetened beverages. And it has been shown that the higher the tax, the lower the consumption. The same logic applies for tobacco also. So we have to find ways of really regulating the food industry, because food industry can do a lot of good also. They can also prepare a lot of healthy foods, because people do need those kind of alternatives. But this type of thing has to be very strictly regulated, and other countries have done it. It's quite tough to do that, but it would need to be done looking at the bigger public health needs of the country. Now, I just want to move on to, what is the time? It's 3. So maybe another 10, 15 minutes I'll take. The lot of advances in technology now, artificial intelligence, everyone talks about it. I think many of us still don't really see the full potential. But of course, there are so many startups, so many companies now using large language models, LLMs, to, whenever I have tried ChatGPT to find out something, I've been quite impressed with what it comes up with. Sometimes there are some mistakes also, so you can't take everything it's giving you as correct, but it does synthesize the available literature very, very rapidly. So it can be quite useful in a number of ways. We know that AI is going to be used a lot more in drug discovery, drug development. It can be used across, I think, practically every field, to help to do things better and faster. In the healthcare industry, the AI is being used now to read X-rays automatically, to read slides, pathology, especially in places where there's no radiologist or pathologist. It's very helpful to have something like this. It's being used also where there are no ophthalmologists, to look at retinal scans and pick up diabetic retinopathy. Many different applications are there. And also, people are saying now that it can be used by healthcare providers on their phone to tell them how to deal with a particular patient by giving some, you know, clinical algorithms to follow. But all of this needs to be tested, and we need much more research on whether AI is useful to improve health outcomes or not. Again, during the pandemic, we saw the digital technologies, really exploding and widely used. We saw apps being used. We saw telemedicine being rolled out, and India was ahead of other countries again because we already had a very nice, robust digital platform. So we had e-Sanjeevani telemedicine program. Now we have e-Telemanas program for mental health. So a lot of opportunities there. But still, there are places, as you were saying, I visited recently in Orissa, where there's no network coverage at all. So the same solution may not be able to reach everywhere, but certainly for large parts of the population, we can explore how do we use these tele services as well as digital tools much better to reach people and also empower them with knowledge. The kind of information that they need can be much more easily provided, and I think many government departments are not now rolling out those kind of schemes. It helps you to really connect with people. We have also the MS Swaminathan Research Foundation. We have apps both for farmers as well as for fishermen, which gives them the kind of weather information and other information that they need to know, on a particular day, and it's updated all the time from the IMD data. And there are lakhs of fishermen now using that app and finding it extremely useful. So I think technology definitely is going to play a very big role, and we all have to become tech savvy. Um, the other side, of course, also on the biotech side, there's a massive explosion of knowledge, of understanding. And again, I think the pandemic really accelerated, I think, some of the disciplines around understanding of immunology, of virology, of molecular mechanisms, and also of the different vaccine platforms. We had never heard of a vaccine platform using mRNA or DNA or even a subunit protein. So many dozens of vaccine platforms were deployed, and so much new technology, including using different materials, to develop the PPEs, to develop rapid diagnostic tests, etc. So all that knowledge and capacity and technology can be now applied, to deal with some of our other public health challenges. In terms of genomics, of course, thanks to, again, the virus, we had so much of surveillance. Everybody knew what is a variant, what are mutations. I think these all became very common words used in a day-to-day language. And again, the networks that were created, the INSACOG network in India, for example, that was monitoring COVID variants, certainly now is looking at how they can use it, to do overall surveillance. So for us to really capture I think, potential of both all these advances in technology, we need our own data sets also. Because if you see artificial intelligence, it works basically on whatever data it's trained on. And one of the risks of using AI are the biases that creep in. Because the algorithms, if they are developed in certain part of the world with certain population data, they may or may not reflect what is needed in some other population. So this is why for AI applications, you have to train it on your own data sets in order to have make sure that that the algorithms are working well, for our own population. So I feel that a challenge that we have, and as a scientific community, we really need to address, and probably the CSIR working with ICMR, DBT, etc. We should really look at what are the gaps in knowledge in terms of our own population. One thing we have less of is longitudinal population data. We have many cross-sectional surveys that get done, but we don't have cohorts many, like in other countries. Like the UK Biobank is a good example of a cohort that was set up about 10 years ago. And what they did is they enrolled about 500,000, and then I think they finally went on to enrolling 1 million individuals from across the UK, and they took consent from them. And it was possible to do there because I think the UK health system is also such that all the data is captured through the NHS and is available centrally. But they collected blood and they sequenced everybody's genome, and then they did a lot of tests, MRI scans, and baseline investigations. And then basically every few years you start looking at the diseases that are coming out in that population and connecting the initial genomic data that you had and other blood assays, etc., with what happens to the individual over a period of time. A lot of discoveries have been made now in terms of connecting certain genetic factors with the risk of developing certain diseases, and also I think a lot more in-depth understanding of diseases itself, and also that then helps to develop therapies. So it of course takes a lot of investment, because it's not going to be very cheap or easy to follow up people. I know in India, I think the DBT has the 10,000 genome project, but I think the difference is that it's not a population that's going to be followed over a period of time. So a one-time genomic study is not going to give us much information. It will just show the diversity of genomes in India. We already know that there's a lot of diversity. But what happens to people with different genetic profiles over a period of time? That type of investment, perhaps all the science departments together could make as something that's going to benefit, India as a whole, and it will spur a lot of innovation and a lot of new R&D and ideas will come up from something like that. In terms of when I was at WHO, at the beginning of every year, we would used to come out with, what are the leading health challenges for the coming year. Of course, some of them used to be around catching up with immunization, with antimicrobial resistance, mental health, and so on. But I can just list a few of the 21st century health challenges according to WHO. I'll just end with that. The first is the climate and health issue. So we know that global warming, air pollution, air and water pollution, and loss of biodiversity, these three things are going to impact our health in a very big way, both directly and indirectly. We're going to see vector-borne diseases in places we have not seen. We're going to see longer periods of heat exposure, and especially the people who have to work outdoors and who don't have the kind of protection that we may have, and with air conditioning, etc. We're going to see a lot of those type of disease impacts. And it also disproportionately affects women, children, and the elderly. So again, the burden of the climate impact is going to be on those groups. So that's certainly something we have to think about. In terms of mitigation, the government has been very progressive in terms of the energy transition, in terms of the electric vehicle transition, but we also have to think in terms of adaptation, because some amount of global warming has already occurred. It's going to be irreversible. That is going to have impact. Coastal communities are going to be differently impacted from people living in cities or people living in semi-arid zones. So for each agroecology, we will need to think what is the best adaptation, and governments will have to put in place those systems. Improving access to medicines. This is a global priority. But for us, I think it's more a question of prioritizing what are our big public health challenges today for which we don't have the necessary products. I think because of our industry, we are very lucky that we get a lot of affordable and high quality medicines and vaccines, but still there are diseases. Let's take cancer, for example, and some of the newer treatments that are becoming available, the personalized therapies for cancer, the genetic therapies, gene therapies for certain diseases. These are all things in which we have to invest in our own indigenous capacities so that we are not dependent on imported, very highly expensive uh, technologies. So I think investment in antibiotics, in antivirals, and in treatments for cancer, but also for some of the neurological diseases which are also growing as the population ages. We're going to see more of those neurodegenerative diseases as well, and so we need to research on both prevention and treatment. So those type of things we have to think of for the future. Of course, there's a lot of pandemic preparedness, etc., that's being discussed. There is a committee that Dr. V.K. Paul is chairing. He's set up, so I'm a member of that committee. So we're trying to develop a blueprint for India on how to prepare and prevent uh, future pandemics, looking at all aspects from surveillance to community preparedness to development of countermeasures, as well as to communication, etc. Um, Simple things like water sanitation in healthcare facilities globally. Again, this is a priority because 50% of healthcare facilities globally don't have access to running water and sanitation. So again, that's something that we are building on here. Our primary healthcare system is being strengthened now through the health and wellness centers, through the Ayushman Bharat mission. And so very soon we hope that every individual will have access to a healthcare center within about 4 to 5 kilometers of their house so that they can get primary care very close to their homes. Because in India, we still have a very high out-of-pocket expenditure. So if you really look at what individuals spend, 60% of healthcare spending in India is still out of pocket. And uh, this has been going down. I think from 60, it's now come to maybe 50%. But still, that means a large burden of healthcare expenses is coming out of people's pockets. The Ayushman Bharat program takes care of the poor people, um, about I think 400 or 500 million of them. But there are still a large number of people in between who don't have private insurance, who don't have government um, like the ESI or the CGHS, and so they fall between the cracks. So again, preventing catastrophic health expenditures is one of the goals in the SDG 3, in the health for all, along with universal health coverage. And then I think the trust issue is also something that came up during the pandemic. Again, I think we were lucky. I just read a paper today that showed a global survey of people asking about their trust in scientists. So apparently, India, Egypt, and Nigeria were at the top, where the majority of the public actually had a high level of trust in their scientists. And they wanted scientists to communicate more actually with the public. But in many countries, especially the high-income countries, this trust is relatively lower. And during the pandemic, we saw a lot of misinformation and disinformation. So in WHO, we used to call it the infodemic, when you get so much of information that you don't know what is true, what is not true, and a lot of rumors and things were being circulated through social media. And that actually had a very negative impact in many countries where vaccination rates were very low because people were getting influenced by these messages. Again, in India, we were lucky that did not happen. We had excellent and very high vaccination coverage, but this is a risk actually for the future because social media is there everywhere. It's growing, and so as scientists, we have to learn to communicate. So the message is really that it's not enough to do our science. We also have to learn to communicate what we're doing, why we're doing it, how does it impact the public in a way that public can understand and relate to what we're doing. It doesn't come easy, of course. Everybody is not a born communicator, but I think all science departments, ministries, institutes really need to think about how to improve science communication. And I know that you have also a big program for outreach to school children And that's really very good in Chennai. In fact, we work with some of the CSIR institutes in Chennai. We have a program for corporation school children to expose them to scientific laboratories and experiments. And they spend about 15 days with us. So part of that, they are now visiting CSIR labs also in Chennai. And they get very, very excited and motivated. So I think motivating young people, encouraging more people to get into science, particularly we want more women in STEM. We also have to make sure that they have the right policies to. Um, and then finally, I think, Dr. Bhan always used to say that let's celebrate our achievements. Let's not always be very cynical and sad that, oh, we have so much more to do. So he said we should always be happy. For a large country like India, if the glass is half full, we should be happy because we have accomplished a lot. And once in a while, we should step back. We should celebrate what we have been able to do collectively. And then, of course, we should also think ahead what more needs to be done. And I'm sure that you have developed a vision and a strategy. There could be some very short-term goals, low-hanging fruit. There's a lot of intellectual property that's sitting in labs actually around the country. That's what I feel, that scientists work on something. They have a very good initial proof of concept, but then it never goes any further for various reasons. It could be a PhD student who leaves, or the funding finishes, or we don't have the right expertise to take it forward. So I think it would be worth actually looking at any such intellectual property that may be sitting, that may be still worth, there's still a need for something like that to take it forward, through partnerships, both public and public-private partnerships. There could be some very short-term such goals set, to solve in a mission mode certain issues. I'm still hopeful that there will be a mission to develop a TB vaccine, because we don't have, apart from BCG, we have a few now in trial. So let us see if some of them actually come out. But we need many more of the, we had for COVID something like 450 vaccine candidates that were developed around the world. So we were used to wonder, how are we going to track these 450 candidates? Of course, at each step, they get reduced. But still, even those which went into phase 3 trials were, several dozen COVID candidates went into phase 3 trials. And about 12 of them finally got WHO emergency use listing. So for TB and for diseases like that, malaria, we also need much more R&D, so that some of those products at least may turn out to be both safe and efficacious. And Dr. Bhan also used to talk about, I think he's one of the really great minds we've had, so innovative in his thinking, because he developed so many new financial instruments also in the DBT that was able to launch programs with much more flexibility. And he always talked about thoughtful risk taking. He used to say that in a country like India, we cannot take very big risks because we're not at that stage where we can put a lot of money into something and we don't know what's going to happen. But he used to say thoughtful risk taking. You can make some bets somewhere, and it may fail, it may succeed. But if you never take a risk, then you're not going to make anything big and transformational happening. So I think, as I close, the 21st century certainly is, I think, the century of science and technology. There's no doubt about it. I firmly believe that that science and technology can help solve many of the contemporary problems that we face. We just need to identify the problem and take the right approach and find the right partners. I think having the right teams, especially multidisciplinary teams, I have learned throughout my career that one person's mind is not enough. If you have 10 people working on a problem, each one coming from a different perspective, you're much more likely to solve that problem, because there are so many good ideas on the table. So we have to think of some transformational initiatives, transformational mechanisms to achieve those. But I strongly believe in partnerships and in collaboration. And again, we saw during COVID, it was only through partnerships and collaboration that we were able to achieve many of the things. So we used to talk about science, solutions, and solidarity. So science, we believe in, will help us to get to the bottom of the problem. The solutions it will give us, but then you need the solidarity also. And there we were talking about global solidarity, which was very lacking at that time. It was difficult to get all countries to agree. A lot of fighting was going on, but I think for us, the solidarity may be between agencies, arms of government. How do we get between public and private, etc., to work together on the same problems? And I want to end with something that my father said, and he always used to talk about, because very kindly mentioned him and the Bharat Ratna, and thank you very much for your warm wishes to everybody. But he used to say that the Green Revolution came about uh, as a symphony, and it was not the scientists alone. And the other day, I was listening to some of the farmers from Jaunti village, the seed village, where he used to actually go. And that's where they were experimenting with the high yielding varieties of wheat initially, then rice. And some of those old farmers still remember my father, and they were talking on the video about how he used to come on Saturday, Sunday to their homes and sit with them and talk to them about how it was going, how the field was doing, the crop, whether it was faring well or not. So it was he said it was a symphony between scientists, the farmers in that case, since they were the ones to do the growing of the crops, and the politicians. Of course, there was a very strong support politically also for making India food secure at that time. And so the government of India, this was a big risk actually. It was, nobody had thought that it would solve the problem. It was some high yielding varieties coming from Mexico and the US that were then adopted and then tried in India. So it was a risk, but it was a risk that was a thoughtful risk, and the government decided to back it. And it only became a success because the farmers were part of that journey. They were part of the trials. They adopted it. They found that it was useful and benefited them. And so I think for science to succeed, the message is that you need the right policymakers, the political backing. You need also to take the community along. Whoever that target community could be, industry, in the case of CSIR, it could be the general public, it could be the health community in the case of ICMR. So if you are able to bring them together and work in a good partnership, then I think that the sum of parts actually adds up to much more than one, and then we're able to achieve success. So I hope that uh, that the few thoughts that I shared with you were useful in any way. I can, of course, take questions or any comments if you want to open it up to discussion. But once again, thank you all so much for a very patient listener. Thank you.